Welcome, student. I'm Dr. Marwa Daif, lecturer of the chest department in Ain Shams University. Today, we discuss the local chest examination as a part of an inspection, palpation, percussion, and auscultation in details. Lovely student, the first step, it is the inspection. And before you starting the point of examination, you should stand on the right of the patient and greet your patient. صباح الخير. Introduce yourself. أنا دكتورة مروة ضيف. ممكن تسمح لي أفحص حضرتك؟ Then exposure. The exposure of the chest from the clavicle to the umbilical. Okay? Then will be warm your hand and wash your hand by the gel. Then start the first step. It is the inspection. Firstly, this inspection. What is the point you should be comment? The first will be comment on the movement by asking the patient to take breath deeply. خد نفس جامد وطلعه. You inspect that from the right of the patient and on the leg. Now, the movement is equal movement. The movement to comment equal or unequal to deduct the symmetry. So the chest is symmetrical in equal movement while it's asymmetrical with unequal movement. What is the shape of the chest? Shape of the chest, it depends. It's symmetrical, so you should measure the transverse diameter from the anterior axillary line from both sides and the anteroposterior diameter from the anterior to posterior axillary line. Measurement is 7 to 5. This is mean. This is the elliptical shape, normal shape of the chest. While it is reversed ratio or equal, or this ratio is disturbing, this mean on hyperinflated or barrel-shaped chest like box. In this case of COPD patient. Okay, then the patients, it is a comment of the shape. So equal movement, symmetrical, so deduct the transverse diameter to anteroposterior diameter to deduct the shape, which is a normal elliptical or hyperinflated. While asymmetrical, like bulge retraction, you should deduct the retraction. It is limited movement on this side, so you remember fibrosis and collapse. While the bulge, remember pneumothorax and pleural effusion. Then it is some abnormality shape of the chest, like kyphosis. It is an anterior curvature of the vertebral column, while the scoliosis is lateral curvature. It is the abnormality of the back of the patient. While the abnormality in the anterior, it's abnormality of the sternum. When the drawing of the sternum inward is called pectus exudatum, like the shoemaker. While the patient with the sternum protruding outside like pigeon chest, chest الحمام, وده it's called pectus carnatum, and this case in old in patient with rickets, usually it is a problem. So we comment on the shape, movement, symmetry. And look with the inspiration, the subcostal angle. It is the angle between the last two rib in the right and the left. You can inspect it and ask the patient to take deep breath. خد نفس جامد وطلعه. It is the only step we can put your hand in inspection. So it is while subcostal angle is a confirmed hyperinflated chest. Then you have 2 points, scan and pulsation. In your scan, you deduct for any abnormality like pigmentation, dilated vein, and any scar. You describe the scar. It's old scar, recent scar, and where is the position, intercostal or on the rib, on the clavicle. It's pigmented, it's complicated or not, like the scar of intercostal tube or surgery as lobectomy. Then pulsation. You detect the pulsation, usually the normal visible pulsation is epigastric and apical, while other pulsation in some abnormality like the left parasternal or right parasternal with associated cardiac condition or pulmonary hypertension. You ask the patient to hold the breath. خد نفس واكتمه. And look tangentially. I see visible epigastric pulsation. Why the apical pulsation not visible? So in inspection, just see, no palpate. Okay, then the 2 point, it is related to respiration. Ask the patient to respirate normally and no allow the patient to detect what you do. Will we calculate the cycle of respiration in 1 minute? It's normal between 60 to 20 cycles per minute. While the pattern of the breathing, خد نفس جامد وطلعه. The pattern of the breathing is thoraco-abdominal or abdominothoracic. Here is thoraco-abdominal. So my comment, the patient by inspection, equal movement, symmetrical, hyperinflated shape with wide subcostal angle, and the pulsation visible epigastric pulsation with no visible other pulsation, and the skin there is no abnormality detected, and the respiratory rate's about 60 cycles per minute, and the pattern of breathing is thoraco-abdominal. Don't forget in the inspection, it's have 2 steps. The step on the right of the patient and look anteriorly and tangentially to an inspection, the movement and the pulsation, and ask the patient to deep breathe. خد نفس جامد وطلع. And then on the leg of the patient, ask the patient to take breath. خد نفس جامد وطلعه. To detect the symmetrical and indirect pulse and retraction. So, to summarize your inspection, you should comment on the shape, movement, subcostal angle, and symmetry, pulsation and skin, respiratory rate, and pattern of breathing. The second point is palpation. How to palpate the patient? To confirm the 2-step pulsation and movement. The first, to confirm the movement. The lung-like pyramid, so it is infraclavicular area, 2 thumb is parallel to the middle line, and your hand in the apex like that. Take breath, خد نفس جامد وطلعه. The lung have like pyramid, ثلاثية الأبعاد. بتشوف اللونج بتتحرك ازاي is equal في كل الاتجاهات عشان تقدر تؤسس الموفمنت. movement، خد نفس جامد وطلعه. خد نفس جامد وطلعه. In upper axillary also خد نفس جامد وطلعه. خد نفس جامد وطلعه. On the back خد نفس جامد وطلعه. خد نفس جامد وطلعه. خد نفس جامد وطلعه. To assess the movement, infraclavicular and mammary and inframammary, upper and lower axillary, and the suprascapular and infrascapular with interscapular area. I find this equal movement. Sometimes some authors say that tenderness can be assessed with movement. By explain that to the patient. Do you have any tenderness? عندك أي مشكلة في أي ألم في أي جزء وأنا كنت بفحصك؟ And sometimes it's a lone step by take the patient and lock your face patients by slightly compression in all direction and the same area will be assessed. After examine the tenderness and movement will be confirmed the pulsation. By one hand, ask the patient to take breath and hold. خد نفس واكتمه. Epigastric pulsation. خد نفس جامد واكتمه. Apical pulsation. Left parasternal and right parasternal pulsation. Palpable or not palpable. In the inspection, you have visible epigastric pulsation, but not palpable epigastric. Epigastric pulsation have 3 sources: aortic in origin, and the tips, it is right ventricular hypertrophy, and in the other side, it is the liver pulsation. And there is in this patient no palpable pulsation, apical in hyperinflated due to the hyperinflated chest and encouragement of the cardiac notch, so apical pulsation is not palpable. So, no tenderness, equal movement, and the pulsation, no palpable pulsation. We have 2 palpable palpable bronchi and palpable TVF. Palpable bronchi, by one hand, ask the patient to breathe deeply. خد نفس جامد وطلعه. And your hand is have the direction of the bronchi. خد نفس جامد وطلعه. خد نفس جامد وطلعه. خد نفس جامد وطلعه. And the same area, infraclavicular, mammary and inframammary, upper and lower axillary, suprascapular, interscapular, and infrascapular. To detect the secretion in the bronchi, and if they find it, to confirm, ask the patient to cough, to expectorate, and you can find it disappear. So it's called palpable bronchi. Palpable TVF. TVF is a Latin word. Tactile vocal ferments. بالعربي هو الرعشة المحسوسة من إصدار الأصوات من الأحبال الصوتية. بنطلب من المريض إن هو to take sound 44 بالعربي أو بالإنجليش 99. الفكرة إن أنا بخلق high frequency and low frequency sound من خلال الabduction and adduction of the vocal cord. Normally الساوند بيعدي من خلال التراكية without any modification. يمشي من خلال البرونكاي without any modifying لحد ما يوصل للألفولاي بيحصل عليها modifying to absorb the low frequency only to passing the high frequency. So سموها في الكتب لأنها من الألفولاي في الأوسكالتيشن اسمها vesicular breathing، وده اللي بيعبر عنه في الأوسكالتيشن. while في التي في اف لو الساوند عدى زي ما هو بالهاي فريكونسي ولو فريكونسي من الفوكال كورد التراكية لحد ما وصل للألفولاي without any change، ده معناته إن في مشكلة في الألفولاي diseased، يا إما صماء تماما زي في حالات الكونسوليديشن أو حصل completely destruction زي الكافيتيشن، أو إن هي مليانة بفلويد زي في البلمونري فينس كونجشن، وده بلاقي ان هي جزء منها اير وجزء منها فلويد، وبالتالي بيبقى عندي مشكلة في الالفولاي غيرت الموديفاينج ساوند الطبيعي اللي بينتج منه، وبالتالي هسمع نفس الساوند اوف هاي فريكونسي اند لو فريكونسي هحسه بنفس ايدي في نفس الاريا اوف الفولاي which is abnormal، لانه هو بيطلق عليه في الاوسكالتيشن برونكيال بريذنج، ونورمالي مفيش برونكيال بريذنج هنا، وده نفس الفكرة بتاعة التي في اف وانس انه هاي هو نفس المكان اللي هتسمع فيه في الاوسكالتيشن برونكيال بريذنج. عشان كده ببدا اقول للعيان قول 44 44 44 44 44 44 44 44 and the same area infraclavicular mammary and inframammary, upper lower axillary, suprascapular, interscapular and infrascapular. To compare equal or unequal, usually is equal TVF while it's accentuated or high TVF or diminished TVF. High TVF usually it is disease of alveoli, parenchymal disorder, like consolidation, like collapse, underlying patent bronchus, like cavitation. While diminished, in some cases, it's lead to away bronchus from the chest wall, like the pleural effusion and pneumothorax. In this patient is equal TVF. Last step, it is a tracheal examination. Ask the patient to stand on. Okay. Let your left patient on the head and ask the patient to close your hand on the chest. Okay, slightly extended, and by the index will be examined the trachea by two angle. When this in the anatomy, sternocleicomastoid muscle with the sternal angle. Usually it is have two groove. This two groove usually is space. By the index there is no fullness. Whilst have fullness or bulge from the one side, this means the trachea shifted to the side of the bulge. So the trachea central or shifting to the right or the left. So the trachea here is the central. So to summarize, the examination is equal movement with no tenderness, no palpable pulsation, and no palpable bronchi with equal TVF and the central trachea. The third step of local chest examination, and very important step, is percussion. What is the code of the percussion? By the hand, middle to middle finger will be percuss. It's to vibrate sound. You palpate this to the lung like ultrasound to sense this vibration and to sense it is resonance or dull or hyperresonance or impaired note or tympanic. And it is the light percussion all the long except upper border of the lever and the back, especially in tidal percussion, will be started on the line. You have midclavicular line and the anterior axillary line and the posterior axillary line and the scapular line. I will be start to detect the second intercostal space by the angle of the Lewis, and in the second space at midclavicular line will have light percussion very gently to detect the comparative percussion between the two lung, its equal resonance or there is impaired note or dullness, and usually the lung is resonance because it's full of air. Then will P start to detect which is called impaired note. And this is an impaired note. It is to detect. Ask the patient to take deep breath. خد نفس جامد واكتمه. And this is the shifting dullness from the dull to the resonance indicate the side of the upper border of the lever there in the sixth intercostal space at right midclavicular line. So we start to comparative at the midclavicular axillary line and infrascapular line to detect the equal comparative, and there is equal resonance with upper border and the sixth intercostal space at right midclavicular. So direct percussion of the bone by 3 middle finger, it is the second step to detect any tenderness and crepitus in surgical emphysema, especially patient hyperinflated. You should exclude there is any. Also by 3 middle finger at the back, scapular, upper and lower, and the spine of the vertebrae to detect any complication like the pain and the crepitus or tenderness. Then direct percussion of the bone, comparative percussion with detectors usually associated upper border of the lever. Now, special zone. What is the special zone? We have 3 special zone. Peer area of the heart هي المنطقة العارية من الرئة اللي هي بتبقى منطقة الكاردياك نوتش، ودي من 4 ل 6 على left parasternal line. عندي بعد كده TROPS area. TROPS area, it is the area for the fundus of the stomach. What is the border? It's the 5th intercostal space with 8 costal cartilage and 9 and 10 on the mid-axillary line. Okay, this is the area of the fundus of the stomach. Crohn's isthmus, it is the area of the apex of the heart. Sorry, apex of the lung. It is the area of the apex of the lung. And this is have the patients will be, it is a triangular in the apex of the lung between the clavicle and the scapula. Then we percuss this area. Light percussion on the pair area usually is dull because it is expressed the cardiac note, while it is resonant, this means encouragement of the lung on the heart. The TROPS area we percuss and usually is tympanic due to the fundus of the stomach. So it's become dullness, you should be suspect of the pleural effusion or hepatomegaly or the splenomegaly or the hydronephrosis or the problem in the fundus of the stomach like cancer of the stomach. And then the percussions of the Crohn's isthmus. Okay, the apex of the lung usually also resonance with become dullness. You should ask about thoracic outlet syndrome or apical fibrosis or pancreas tumor. So to summarize the percussion, direct percussion of the bone, there is no abnormality detected. Comparative percussion is equal resonance on all line. By the upper border of the lever is the 6th intercostal space at right midclavicular line, while the special zone per area is resonance and the TROPS area is tympanic and the Crohn's isthmus is equal resonance. Lovely students, this is the last step, it is the auscultation. The stethoscope, you have the airpace and the diaphragm and the cone. Will be auscultated by the diaphragm in the chest. Starting on the line, midclavicular line, in in intercostal space and the anterior and posterior axial line, then the scapular line. Ask the patient to take deep breath. خد نفس سوري جامد وتخرجه. Again. 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 On the back. خد نفس جامد والله. In enter spinous space. Then infrascapular area. In the auscultation, you comment in the quiet breathing on the type of the breathing, equality, and the adventitial sound. The type of breathing, the explanation of the tactile vocal forms is the same explanation of the type of the bronchial breathing. It's abnormal breathing. It's a tracheal sound. You can detect by auscultate the trachea. It is the typical bronchial breathing. And the bronchial breathing is abnormal in the chest wall, and the same indication of high TVF is equal to the pronounced bronchial breathing, like the consolidation, cavitation, and collapse with patent bronchus. While diminished and auscultate with pneumothorax and pleural effusion, diminished of this TVF, this is the same of diminished of breath sound. So the breath sound, it is a vesicular breathing. It is modifying the high frequency or low frequency by the normal alveoli, so صوت حفيف الشجر. So the vesicular breathing is a normal breathing, expiratory and inspiratory. Will become harsh, usually in prolonged expiration and the disease like the COPD patient. And another abnormal, it is the explanation of bronchial breathing. In this patient is equal breathing with the harsh vesicular breathing. Adventitial sound. We have two adventitial sound, rhonchi and crepitation. Rhonchi, it's mean airway disease and usually obstructive disorders and usually start expiratory, then inspiratory, never ever to be inspiratory before starting expiratory. And it is have two sound, sibilant, like sofara, and sonorous, خروشة. And the difference between us in pathology, sibilant rhonchi is narrowing of airway. You imagine the narrowing is all the airway. No, the narrowing, it is area, patch. So the sound comes from the wide area to the narrow. It is the turbulence of the flow, it's disturbance, so they auscultate sibilant rhonchi. And it is in symptom and sign called wheezes. اللي بيجي يقول لك العيان اللي عندي صفارة أنت بتسمعها بالauscultation sibilant rhonchi. Sonorous, it is the secretion in airway. When ask the patient to cough, when auscultates, كح. خد نفس تاني. After the cough, the auscultation will be clear from the sonorous rhonchi to differentiate between sibilant and sonorous. Then will be the crepitation. The crepitation is a parenchymal disorders. It's usually starting in inspiratory, then expiratory, never ever to be expiratory before starting in inspiratory. And it is indicated the alveoli disease. It have two sound, fine crepitation, fixed or non-fixed, and coarse crepitation. Fine crepitation, this is mean the alveoli still have air with other fluid like blood, like water, like any associated fluid, so like alveolar hemorrhage, pneumonia, lung abscess. This is the pulmonary venous congestion is fine crepitation. So the fine crepitation fixed in some disease like fibrosis, mixed fibrosis with air, it is not changed with sometimes is progressive. While the non-fixed like pulmonary venous congestion, when give the patient diuretics and auscultate again, it is disappear the sound. Fine crepitation like the صوت الأزاز اللي بيحوط الأجهزة الكهربائية لو انتوا لعبتوا فيه بيديني صوت الفاين crepitation. الكورس كريبيتيشن صوت كركرة الشيشة، وده بيبقى صوت عنيف جدا نتيجة ان الالفولاي will be completely distracted like in the cavitation, and it's usually even with cough. after cough لو قلت لعيني كح الصوت مش بيختفي، ولو حصل انه اختفى واحنا عارفين ان في cavitation دي بتبقى مشكلة ان انا بيبقى عندي problem like bronchopleural fistula. Then the auscultation will be summarized in this patient. It's equal intensity of the breathing and the type of breathing, harsh vesicular sound with expiratory sibilant bronchi all over the chest. So, in summarize, auscultation is equality, type of breathing, vesicular, harsh vesicular breathing and bronchial breathing, adventitial sound, rhonchi, sibilant and sonorous, usually expiratory, crepitation, fine, fixed or non-fixed, coarse crepitation, usually inspiratory. Thank you. To summarize your examination, you should in the inspection fulfill this point: movement, shape, symmetry, subcostal angle, skin, pulsation, and the respiratory rate and respiratory pattern. In the palpation, you fulfill the point of movement, pulsation, two palpable bronchi and palpable TVF, and the trachea to detect central or not. In the percussion, you shed this point. It is a direct percussion of the bone, comparative percussion of both lung and the spatial zone. On auscultation, you should comment of the type of breathing and the spatial adventitial sound and equality of both lung. Thank you.